الله جميعا. مساكم الله بالخير. أنا اسمي أول شيء فيصل الزهراني، أنا orthopedic trauma fellow في الحرس الوطني بالرياض. اليوم إن شاء الله راح نتكلم عن tibia nonunion. أنا أقترح إذا يناسبكم إنه نبدأ أي questions تكون في البانل، وراح يكون عندنا multiple stops. stop الأولى بعد ال theory part أو الأشياء science part، بعد after each case we will have a stop for any questions so we can move on. و at the end راح يكون في ال stops. ما أدري إذا شباب في polling system، ممكن إن في بعض الأشياء اللي راح تكون questions for everyone. We can see what you guys think.
خلاص تمام دكتور.
ممتاز، بسم الله. Our topic today is tibia nonunion. راح نتكلم إن شاء الله عن our learning objectives. By the end of this session, you will be able to, inshallah, define and classify non-union by type, employ appropriate preoperative workup for the non-union patient, holistically approaching the patient, and then identifying the patient's need for stability, biological improvement, void management, and infection control, and after that, understanding and applying methods to gain these principles. Bismillah, nabda. Okay, definitions and classification. So, definition of non-union is actually not as simple as we thought when we started. For me, when I started preparing for this topic, because historically we know that there is a certain period of time, 3 months of no signs of progressive healing, 3 consecutive months, or 9 months. However, in reality, it's actually failure of bone to heal after adequate time for that specific type and location of fractures. So each fracture in the body has specific personality, let's say, for healing, that whenever that is disrupted or delayed or not going into the same progress it should be, then non-union happens. So that's mainly the definition. We can classify non-unions in a broad way as infected or sterile. Infected non-union is infected non-union. There is no subclasses for that, but for sterile non-union there is hypertrophic, oligotrophic, and atrophic. Other names that are commonly used in trauma are elephant foot for the hypertrophic, and horse hoof for the oligotrophic and the atrophic. Okay. So I decided when I was preparing this topic that in order to talk about non-union, we need to know a little bit about union itself. So how does bone heal? So because whenever we understand the conditions and the way the bone heals, we can understand when it goes wrong. So bone healing as a tissue is something miraculous, actually. Bone does not form scars, even though you see sometimes callus or anything, but there is no scar tissue, meaning there is no fibrous tissue in between the bone tissue that was broken. Bone actually builds new bone, which is unique to bone tissue. Even in liver, there will be some scar tissue, but bone does not have scar. There is always stem cell activation in any fracture healing process that goes throughout the age of the patient. There is complex signals pathway. So it is something that's very powerful and very amazing and has this much of advanced biology. So how does any of this go wrong? Bone biological properties do not come unconditionally. So bone does have this power, this amazing power, but does not come without conditions. Bone needs certain mechanical environment for this biology to work. So the bone has this biological superpower, but in order for that to happen, it needs strict, exact mechanical rules for this biology to show us its wonders. Okay? So we need mechanics in order for biology to work. There is an interfragmentary strain theory. Strain is one of the main concepts that links biology to mechanics. The strain theory is simple. Strain means the motion at the fracture site divided by the original fracture length. So if you have a fracture in the femur, let's say, and the fracture itself is 2 centimeter long, whether it's transverse, oblique, or spiral. The length of the fracture line itself is 2 cm. So the motion at the fracture site divided by the original fracture length is the strain. So if the fracture was moving completely unopposed, so 100% or 2 cm divided by 2 is 1 by 100, which is percentage, that's 100% strain. If the fracture was 2 cm and it was only moving 5 millimeters, that would be 25% strain. So in order for strain to happen, there has to be motion, and this motion's relation to the original fracture length is the definition of strain. So Stephen Perrin's definition is magnitude of interfragmentary motion divided by the fracture gap size, the original fracture gap size. So tissue in fracture site that can withstand this interfragmentary motion will survive to be bone tissue. Otherwise, fibrous tissue will start to form. So strain of 0%, bone will not be stimulated to form bone. That's why you hear sometimes this fixation is too rigid. That's why there was no healing. So some motion is needed. However, the amount of motion should be well controlled. So if the motion was less than 2%, but there is some motion, but less than 2%, there will be primary bone healing or laminar bone formation, which is the picture here. If it was between 2 and 10%, which means لو مثلا كان طول fracture 10 cm, just to make it easy. So it was 2 millimeter to 10 millimeter of motion at the fracture site, there will be callus formation. If that 10 cm moved more than 1 cm, there will be no bone healing. Instead, those progenitor cells will come, will accumulate, will increase in size, trying to decrease motion, and that's why callus sometimes is big. It's the bone's attempt to control motion. But if the motion sustained was continuously above 10%, there will be fibrous tissue or cartilage that's ensuing instead of bone. So you see, no motion at all is bad. Motion that is well controlled, less than 2%, will give us laminar bone. Motion that is between 2 and 10% of the original fracture size will give us callus, and anything above 10% will not have bone forming there. Okay. Strain again is fracture length or change in length, which is a change in length divided by the fracture length itself. So this is the fracture length. And this is the motion that's happening, these two dots here, the change of length. So this change of length divided by the fracture length times 100 is what is strain. So biomechanically, as I mentioned, motion and bone contact relation to fracture union. Certain motion promotes callus formation. Body attempts to decrease motion or strain by forming more callus. If motion exceeds bone ability to bridge fracture, which is, what's the percentage? 10%. If there's motion more than 10%, hypertrophic non-union occurs. Conversely, as I mentioned, very stiff constructs with a fracture gap, especially, there's any gap. And it was very stiff, which means strain was 0%, which is very difficult to achieve, by the way, will result in no formation of callus, resulting in atrophic non-union. 0 cells will migrate, trying to bridge, and 0 healing will happen. Okay. Now back to non-union, okay? We talked about the points of how bone heals, what are the rules, how is biomechanics related to biology, and now we'll see how does a non-union happen. So for non-union to happen, we need to study 3 factors: patient, injury, and surgeon. Patient factors like smoking, comorbidities, medications, vitamin deficiency, obesity or malnutrition. And then there is injury factors like soft tissue status, comminution, non-loss, energy of the injury itself, and contamination. And surgeon factors, which are excessive soft tissue stripping, inadequate fixation, too rigid fixation, which is a concept that sometimes is missed. Sometimes people think I will make this Fixation very stable, and sometimes it is too rigid, there is no motion at all. Huh? And distraction, or in other terms, presence of a significant gap that inhibits fracture union. And we will come to that actually later. So, knowing that classification of sterile fractures, hypertrophic, oligotrophic, or atrophic, how do we guide our treatments based on those types? Hypertrophic, we can increase stability, right? Because hypertrophic happens when there is too much motion. Atrophic or oligotrophic, we can possibly increase stability, and we will know why, especially if it was too rigid. How will we need to increase stability? And the main bulk is working on biology. Okay, and if it was infected, which is the other main type, then it usually encompasses everything from debridement to antibiotics to plus minus structure, like bone integrity, make sure that there is no necrotic bone, and stability and stimulation, which is biological stimulation. Okay, so far so good? Okay.
Yes.
Okay, great. Variables to consider. In any fracture, there is non-union, we should look outside the box. We try to determine what are we working with. The location of the fracture makes a big difference, whether it was diaphyseal, metaphyseal, or articular. Sterile or infected, the status of the soft tissue, and the alignment of the limb, which is something that sometimes needs to be corrected in order to achieve union. Fixation present, and is it stable or is it too rigid? And bone viability, which usually is assisted by radiographs. Okay. There is this small checklist, but I wouldn't worry much about it because we will have a better or more comprehensive way later on. Um, Whenever you have non-union, you need to investigate and optimize your patient, both investigation and optimization. So take proper history of the patient, proper comprehensive labs that include metabolic, endocrine, medication history, and then examining locally and systemically. Optimizing each factor that you face in order to achieve union. Rule out infection, usually by history and physical, then pre-op labs. Some imaging might be required sometimes, and intraoperative cultures. Then achieving stability in good alignment, which actually matters a lot, and we will see. And this step usually requires surgical intervention. Okay, so this approach, if I get one wish from this presentation, is for this slide to be used as a guide for any non-union, not only tibia. Any non-union, in order for a surgeon to manage non-union always the most comprehensive way while achieving the best results possible, you need this three-step approach. So the first step is trying to determine why the fracture did not heal, which actually is a very basic question that anyone would ask themselves. Any non-union comes to my clinic, I will think, why did the fracture not heal? We have three main things: extrinsic factors, smoking or metabolic; mechanical factors, poor fixation, improper implants or alignment issue; and the third one is biological factors, large gap, infection, or too much comminution. The second main step is determining how to treat based on these factors, which is actually very easy given that you know these factors. Okay, smoking cessation or endocrine review, improving biology, either by treating an infection if present, or improving soft tissue coverage, or improving bone status, adding bone graft, um, reaming, adding RIA or whatever. Okay, and then the other part is surgical implant factors, proper fixation, proper implants, and having adequate stability. And last but not least, improving alignment. The third main part, and this is actually very important, is individualizing treatment and managing expectations. Even though that you have discrete, clear, scientific reason for this fracture to heal, not to heal, and you want to correct that, you need to individualize your treatment. If a patient with non-union comes and the patient is 99-year-old who is non-mobilizer and having a painless non-union, It's different from someone who is an Olympic runner who has a tibia and a nonunion. Okay, what are the patient's goals? What is the success rate of my intervention? And are there alternatives? What's my backup plan? How much can the patient actually tolerate? Some patients will tell you, please just give me this one time surgery so I can go back. Job, I need one surgery. Some of them will say, I want the best results regardless of. It's so important that I will come back to them with every case, actually. Okay, so before I start my case, any questions about the previous slides? I cannot see actually the polls or anything, so whoever is coordinating, are there any questions?
ايه دكتور فيصل،
أهلا.
يلا يعطيك العافيه. واضح النقاط يا شباب. اللي عنده اي سؤال او اي حاجه يفتح المايك ويسال الدكتور فيصل.
إيه تفضلوا قبل ما نبدأ الكيس. في أحد عنده سؤال يا شباب؟ نكمل أجل؟
ايه توكلنا على الله.
يلا بسم الله. So this is the first case. This is a 25-year-old male, a firefighter. Original injury had an NVA with open tibia fracture, bilateral femur, pelvis fractures. The injury happened 10 months ago, and he comes to you to show union. Hello? This patient is healthy, non-smoker, wants to go back to active duty as soon as possible. Okay, these are the x-rays 10 months from the index procedure. Lateral views of the tibia, and you can see actually there is, but this fracture wouldn't. So would anyone volunteer to read these x-rays and try to comment? Any volunteers?
يلا يا شباب، واحد من الار 1 وار 2. علي الثقفي.
No wrong answers here. Just I want to brainstorm, brainstorm. Okay. No volunteers yet. Any level, no problem.
وليد اليامي.
شباب مستحيل شوي، مو مشكلة. Okay.
إيه.
So yeah, it's okay. في other cases they can volunteer, no problem. بس
I can be involved, دكتور. تفضل.
يلا, what can you see?
If this is X-ray
Can you read
for
it?
our patient, there are two X-rays, AP and lateral, as I see. The implant looks like an intramedullary implant with distal 2 screw fixation. I see also, I think there is a plate in the proximal tibia. There are both bone fracture in different levels. This is what I see. Regarding the
You mentioned multiple level fractures where?
there are two level fractures for the tibia, I mean, and the tibia. Both bone fracture, I mean.
ممتاز. So actually that was a very good point when you mentioned the fibula. So the tibia, there is a fracture in the proximal plateau and it's healed. And then at the shaft, which has not healed, correct?
Yes.
ممتاز.
I'm not sure if it's oligotrophic or atrophic, but I don't think it's hypertrophic. معلش الصوت يقطع يا دكتور، ما اسمعك.
دكتور فيصل صوتك يقطع.
other things الفيبولا صح؟ فيها fractures. What?
Yeah, sure. There is a fracture in the mid shaft of the fibula.
ممتاز. Actually, yeah, there are. So what does that indicate? When you see a fracture of the tibia with fractures of the fibula, what does that indicate to you? What does it mean?
I'm not sure, but it might be about stability.
Yeah, it could be, but would it indicate that the fracture
صوتي يقطع يا دكتور، ما أسمعك.
high energy trauma؟ الحين غيرت مكاني يا شباب، ما ادري اذا واضح لكم ولا لا.
إيه واضح الصوت.
الحين الصوت واضح؟
نقول إن شاء الله يعني.
So whenever you have a fracture.
دكتور فيصل تقدس على الصوت شوي يقطع. دكتور فيصل.
There is fractures, or this injury had high energy mechanism. معلش.
ممكن تعيد السؤال يا دكتور؟ أو النقطة اللي تحب تذكرها؟
تسمعوني الحين؟ واضح الصوت؟
إيه تفضل دكتور.
ممتاز.
إيه كذا واضح دكتور.
ممتاز جدا. Whenever you see tibial shaft fracture with fibular fracture, especially if it was segmental or different level, this actually indicates that this whole area had a lot of soft tissue injury. It was a high energy trauma with a lot of soft tissue injury, affecting the soft tissue envelope around the fracture and increasing the risk for non-union. So this I want you to keep in mind, okay? And as you can see, this fixation, I would comment on this fixation. I think it's a proper fixation with good length and good size nail, excellent alignment. But 10 months now, there should be full healing, and there is no healing. So let's move on. So patient walks with an antalgic gait. Patient has a foot drop, and actually from the x-rays you can see the brace marking on the skin, and no draining sinuses or any signs or symptoms of infection. So our workup, and this is very important, whenever you have a patient that comes to you with non-union, you need to do infection workup, CBC, ESR, CRP, and procalcitonin, and they were all normal. Vitamin D, TSH, chemistry, calcium, testosterone, and parathyroid hormone. So what are these orders? What do they look for? What are we trying to rule out? What do you think, guys?
Malnutrition, yeah, for example.
ممتاز. So osteoporosis, malnutrition, any endocrinological causes. And from all of these, as orthopedic surgeons, we would treat if there was vitamin D deficiency, if there was any calcium supplementation needed. Otherwise, patient will need referral to endocrinologist. And I know this is uncommon for us to refer young, healthy patients with non-union, but this should be the practice, actually. These are the AO recommendations now. We should involve endocrinology from the big case that there are certain factors. Imaging, x-rays as viewed, no further imaging was done to the patient. So let's move on. So what do you use? The checklist, the 3 checklist approach to non-union. Number 1 is, why did the fracture not heal? So as I promised, I will put with every case this checklist, and I will try to answer it one by one, trying to incorporate, my goal is to incorporate this checklist with every attempt to approach any non-union. So number one, why the fracture did not heal? Extrinsic factors, smoking, metabolic, no. And something else to support the absence of extrinsic factors is patient had other fractures in the body that healed. Bilateral femur, pelvis, and even the plateau in the same exact tibia. So no extrinsic or general factors on the patient. Mechanical factors, poor fixation, improper implants, limb alignment. Fixation seems adequate, but due to no healing, even though if the method utilized was stable initially, presence of no healing for prolonged period of time compromises stability. So this is the concept that I wanted to reach. Even though patient had good fixation, but had certain period of time where non-union is established, stability should be taken into consideration because no healing, especially if it was atrophic or oligotrophic, stability would be compromised. Biological factors, is there a gap, infection, or too much comminution? Yes, actually, this patient had a pure biological issue, plus minus stability, of course, always. But this is a high energy trauma. There is comminution. Let's go back to the X-ray. Comminution, as you can see, high energy trauma indicators are there, and plateau present in the same bone. Why would the plateau break with the shaft and the fibula break as well? The leg was really damaged, and the drop foot, even though it was not related to the pelvis or the femurs, this side only. So high energy trauma, comminution, a lot of soft tissue injury is what contributed most to this non-union, okay? So that was number one. See, it might take some time in the beginning, but we'll see with the other cases that it will flow easier. So no extrinsic factors, no mechanical factors, however, really biological factors. Number two, determining how to treat based on the factors that you mentioned. Improving biology in this fracture, we can do it by adding bone graft, improving stability or implant. In this atrophy case, increasing stability could be very beneficial, even though the initial fixation was stable, okay? But if you have to go in again to improve something, try to improve it better, okay? Is there a limb alignment issue? No, as we saw in the x-rays here. Actually, excellent alignment, so it was not an alignment issue. So the last point is individualizing this treatment to our patient. So patient is young, he's a firefighter, so very active, and wants to get back to work as soon as possible. Single stage treatment is preferred in this case. So what's our treatment? Now these are the options. If someone can pull them, maybe we can give them numbers. Sorry, I should have put numbers. But what do you think? Would you dynamite? Would you bone graft? Would you resect and laser off? Would you plate over nail with bone graft? Would you remove nail and do plate? Would you have something else in mind? What do you guys think?
I might choose nail dynamization
Okay.
and bone graft. Not sure, sorry.
Okay. Okay.
Dr. Faisal,
Yes.
I honestly would think of none of these options. I would think of exchange nail.
Beautiful. So you are going with others, which is
Yes.
exchange nailing.
Yes.
Okay. Would you add anything to exchange nailing?
I will increase the diameter of the nail.
ممتاز. مين اللي قاعد يتكلم الحين؟ معلش.
وليد السويف.
حياك الله يا وليد. وليد سوير؟
الله. اي نعم.
اهلا وسهلا.
هلا والله.
Okay. So actually, out of all these options, except for the first one, are extremely valid. Not meaning that the first one is wrong, but the most recent studies showed that dynamization should not be the first of your options in tibia. Still valid in femur as of now, but in tibia, dynamization has not showed much promise, okay? However, if you chose to bone graft, you would treat biology. If you chose to resect and laser off, you would treat biology and stability if you did it right. If you plate over nail with bone graft, you treat both, as you see. Plate over nail will give you stability, bone graft will give you biology. If you remove nail and do compression plating, you will do stability and you will contribute some to the biology, which is compression, which can stimulate bone healing. But we will come to our issue. So this is an atrophic non-union. This is a summary of the case. So the main issue is biological. Stability is also an issue, given the fact that it was non-united for 9 to 10 months. Exchange nailing addresses both in this manner. That was actually our choice as well. So I agree with Dr. Waleed. Reaming stimulates blood flow and deposits bone graft at the fracture site. Also, exchange nailing should be done always by increasing the nail size. It should not be exchanging the nail with the same nail size. That's one condition. It should be at least 2 sizes bigger. However, as you know, most of our nail companies, or the most famous ones, they have 10, 11.5, and 13. So there is no 2 sizes bigger. 1.5 size will do. But 2 sizes bigger لو استخدمت مثلا expert nail, which gives you the option of 9, 10, 11, 12, 13, will increase the stability enough. And this option actually, what makes it superior to everything else is it actually is individualized to our patient. Remember, our patient wants to get up and running as soon as possible. And with this approach, exchanging the nail without opening the fracture site, patient will get back to work as soon as possible, and the healing period is actually short. Success rate is really high, it's around 96 to 98%. But the only drawback a little bit is the 6 months period, which is, I don't think it's a big issue as long as the patient can resume activities soon. Okay, so back to our patient. This is 6 weeks post-op. You can see some healing starting to ensue. And this is 3 months post-op. And this patient has actually healed at 3 months. While we expected a 6 months period to complete healing, that patient finished his healing process earlier. And he's back to work, pain-free, with no antalgic gait, and healed fully at 3 months. Okay. Any questions about this case? Okay, great. Moving on. Bismillah. You can stop me at any time, guys.
دكتور فيصل
ها.
معلش بس سؤال بخصوص النيل دايناميزيشن. ذكرت الدكتور انه في التيبيا النيل دايناميزيشن is the least favorable option في الحاله هذه. طيب لو كان حتى لو كان عندنا دكتور hypertrophic non-union في التيبيا.
Yes, because yes, exactly, absolutely. Because hypertrophic means what? The fracture has too much motion, صح?
Yeah, stability problem.
Dynamization will do what?
Increase stability. It will compress.
It will compress eventually, but dynamizing the fracture is actually moving the fracture, which will not increase stability to begin with. So this hypertrophic non-union is the bone saying, please, would you please stop moving? I want to heal. My biology is amazing. I want to heal. Just I need some stillness, moment of no motion, so I can heal. So dynamization would work in femur because it has a lot of soft tissue envelope, which will help in the beginning. But tibia is actually now less favorable than before. It would not be wrong, and for your exam's sake, it's still an option. In orthobullet, when I checked it, actually it is still mentioned, but the latest articles are not with it. So the latest AO recommendations are not with dynamization. It's actually out of practice by most AO surgeons when they did the last non-union conference. Okay, so none of the surgeons present is dynamizing tibias anymore. This is not strong evidence, but this is telling them that with their experience, it's not going very well actually with tibia as opposed to femur. Okay.
تمام الله يعطيك العافية.
It's a valid option, but I wouldn't put it on the top. Okay.
تمام شكرا لك.
Additional points. في some concepts that are engraved in stone in orthopedics, but we need to take them evidence-based. How about taking down the non-union concept? Many surgeons, up until now, they would love to say, okay, I'm gonna open the fracture, refresh the edges, bleeding bone, and then go ahead and compress or exchange nail or whatever. What do you think about this concept? Does it make sense? When you stop and think, it does not at all, because if you have hypertrophic non-union, taking down the non-union means there is actually bone that you want to take down. Hypertrophic is filled with progenitor cells. It's filled with cells that have high potential to heal. Why would you take them down? Unless it was infected or if it was a butterfly fragment that you're suspecting necrosis, just leave it and change the way you're dealing with the fracture, increase stability, improve biology, or whatever extrinsic factor there is that you need to tackle, but leave the non-union, if you see the quotation mark, because it's actually not non-union, it's bone attempt of healing. Just leave it, it will transform. It's progenitor cells that are trying to heal. So don't touch, please. Curetaging and drill hole the bone edges, same thing. If it was not infected or necrotic, do not touch it. How do these points stand with our three-step approach? It's actually they actually do not. They do not conform with our three-step approach at all. Okay, moving to the next case. Would someone like to take the case? So this is a 34-year-old male, a motorbiker, open tibia shaft fracture, comminution with no soft tissue attachment, okay? So this is all already a red flag for his fracture. These are his x-rays. So this is at the presentation. How would you describe this fracture? Anyone?
اوكي السلام عليكم.
Alaikum salam.
احمد زهراني R3.
سهلا.
طيب, this case is showing left tibia fracture mid shaft with comminution with the mid shaft fibula as well fracture.
Okay, excellent. So mid shaft tibia with
Yes.
fibula as well. Okay. So this is open fracture with no soft tissue attachment, bone sticking out of the skin. What are your debridement strategies? How would you approach this fracture in TROP? What would you do?
So first of all in TROB, I will do irrigation debridement and try to refresh the edges and clean it, and then do the primary fixation. How long was the injury?
It's a fresh injury. However, it's an open fracture, Gastello 3A. So you would not think about fixing the fracture immediately, so?
Okay, so after irrigation.
The debridement, how would you debride usually? I wanted to not just mention things in this presentation, to actually tackle them for our own experiences. مثلا debridement, some people would start with the skin, then subcutaneous tissue, then bone. صح? Some people would start bone and come back out to subcutaneous tissue and then skin. What's your strategy usually? وش اللي عادة تسوونه؟
So I'll start as out in. So start with the skin, refresh the edges, and clean any gross contaminants. Also the necrotic tissue of the muscles, I will remove it. And then any fragment of bone with no attachment on it, I will remove it. And then reach to the bone and clean the edges and curate it.
طيب, what if the bone loss, and this is brainstorming for all of us, what if the bone loss was segmental? All of this was not attached to any bone. This was 2-3 cm and it was segmental. Would you take it out or leave it?
No, I will leave it.
Okay, so it's actually controversial, but if it was even full segmental level of bone, as long as it's not articular, no cartilage attached to it, it's a source of infection that needs to be taken out. But as we mentioned before in our three-step approach, we need to have strategy, plan, and backup plan. If this bone was lost, you need to figure out how will you replace it. You need to have a strategy. We'll come to that later, but the point is, if there is a bone segment that is not butterfly, half segment, full segment that's not attached to any soft tissue, it's preferable to take it out unless it was affecting the limb presence. So it was like 12, 14 cm that the limb will not stand without. You might keep it and give it a chance to heal and see what happens. Okay, otherwise it's preferable to take out any bone that has no soft tissue attachment. And then this fracture, open, big incision, a lot of soft tissue stripping. How would you fix it preliminary? What would you do?
Apply next.
X-fix, I agree.
Yes.
Okay. Fine. So this patient, they chose to wash the bride, put him on a cast actually, then later on washed again. It was clean, then they put a nail. Anything you notice about this fracture, this fixation? So when you comment about fixation, we comment about adequacy. So it's a nail that's spanning the whole bone, so it is adequate, صح?
صحيح.
Alignment, that's right. Well aligned. Anything else you notice?
There is a fracture gap.
Yeah, there is a gap. So the question is, how much of a gap is too much? صح?
Yes.
Is there any rule? Did anyone hear about anything that we can use as a reference when there is a gap?
Musculate technique, doctor.
Yes.
No, okay, musculate is a treatment method, صح? No, but when do we employ any treatment option? When is a gap too much of a gap that we cannot just leave for bone to bridge? Did anyone hear about anything?
I think if the fracture gap exceeds 5 to 6 centimeters of bone loss.
Okay, so I think what you are trying to refer to is the critical bone gap for musculate, same as your colleague before.
Yes.
However, no, that's not what I'm saying. What I'm saying is when non-union, how much of a gap can cause non-union? هذا سؤالي.
2.5.
2.5 from where? Medial, lateral, anterior, posterior? Anywhere, everywhere?
I'm not sure, والله.
Okay, but actually this is a correct number, but it's following a rule that's called, there's a genius guy, this guy, Dr. Black. I personally believe this guy is a genius. Reason is, he did a formula, he pulled all the cases of non-union of the tibia, open tibias only, okay? And he saw when do fractures with gap, provided there is no infection, not heal. Whenever there is a gap, how much of a gap does he need for the fracture to develop non-union, provided the patient has no extrinsic factors and no infection? And he came up with this simple yet very effective formula, which is whenever the the average, is it average or mean? Forgot. So when you have a 10 millimeter medial, 10 millimeter lateral, 10 millimeter anterior, and 10 millimeter posterior, you take them all, divide them by 4, and you find something called RABG, which is radiographic apparent bone gap. This RABG, if it exceeds 25 millimeter, the fracture has a chance, a non-union chance of 100%. When it's less than 25, there is a 50 to 60% chance of union, and the lesser the gap, the higher the chance of union, okay? So how do you calculate it? Let's see this fracture here. This is lateral, this is medial, this is anterior and posterior. There is only a gap on the medial part that is 20 millimeter. So 20 plus 0 plus 0 plus 0 divided by 4 is 5. So the RABG is 5 millimeter, giving this fracture a greater advantage of healing than a fracture that has an RABG of 25 millimeters. I hope you understand the idea. Same applies here. Let's see this fracture. It has 10 millimeters from each side, medial, lateral, anterior, and posterior. And the RABG is 40 divided by 4 is 10. This fracture, if it had 1 centimeter gap from all sides, will still have a chance to heal. So 100% non-union when the RABG is 25 millimeter or more. Is it clear? The RIBG theory or it's called critical
Yes.
bone defect. Yeah.
Yeah, doctor, just I want to ask in first line, if do you mean if the fracture gap more than 5 millimeter will have low chance to heal
No.
in the first
No,
line?
no. This slide, you mean here? No,
Yes.
this is actually showing us how to calculate the RIBG. And the study found out that an RIBG of less than 25 has a reasonable probability of achieving union without further intervention. However, if the RIBG was more than 25 or more, patient will have a chance, 100% chance of non-union. That's how strong the study is. So it is actually, when you think about it, it's not easy to achieve. You have to lose a lot of bone to have an RIBG of 25. However, having this cutoff makes it very easy for us to deal with this fracture. So there is a bone gap here. Let's say this bone gap here was 4 cm, okay, for example, or 3 cm. And on the lateral, there is another one that's probably of the same length. So lateral and anterior, he has 4 and 4, 40 and 40, that's 80. And the posterior maybe has 5, and the lateral and the medial has 0, let's say. So patient has 85 divided by 4, that's around 22 RIBG. So this does not mean fracture will heal, but this means that you don't need now to intervene. You can give it a chance. You can intervene, of course, but if it was 25, you should not leave it. At the index procedure, that's the point. If you have an RIBG of 25 or more, at the index procedure, you should not just close it and call it a day. You should do something then. You should do, as your colleague mentioned, musculae, for example, or any intervention that might decrease that RIBG, which is radiographic apparent bone gap. Okay? So that's the point. Okay, so our patient, 1 year later, he has pain. He had an open fracture which was flabbed, flap sealed. Patient is ambulating with a cane, painful or antalgic gait. Let's go back to the fracture. See that what you notice here, or if you notice, there is actually resorption of the edges. It might seem less than before, but actually it's not. See these fracture lines and see here. There is sharp ends. There used to be sharp ends everywhere. So now it's more blunt. Gap is still present. Fracture did not heal for 12 months. So would you diagnose this as non-union?
Yes.
Okay. So 3-step approach in every case, as promised. Why did the fracture not heal? That's the first question, okay? So this is the workup, problem list. Let's go with this patient. So he's not a smoker, does not have any metabolic issue that we know of, but we need to work up the patient. Are there any mechanical factors, poor fixation, improper implants, or limb alignment issue? No, fixation seems adequate. Implant seems proper for the fracture, and alignment overall as well. So, biological factors, is there a large gap? Yes. Is there infection? We don't know, but there are no signs or symptoms of infection, no draining sinus. Flap is sealed, as I mentioned. So, and patient has no systemic signs of infection. And was there too much comminution? Not that much, maybe some comminution, but the biggest factor was biological factor, which is the gap. So how do we treat based on these factors? If he was a smoker or anything, but for this particular patient, we need to improve biology. Treat infection if there was an infection, which less likely. Improve soft tissue coverage. There is a flap, one step down, and improve bone biology. And we'll see how we'll do that. How will we individualize our treatment and manage expectations? Let's see our patient, what does he want? First of all, the workup, vitamin D was low, ESR was 19, so it is a bit high. CRP is 14, also a bit high. WBC is normal. Let's see. Non-union tibia, infection is ruled out even though markers were high. However, cultures intra-op are required. They were done and they were negative. Hello. So biological issue is the main issue, and whenever you have biological issue, you need to supplement stability. Even though the stability was not the original option, but as you can see, after all this time, this area is not stable. Even though the fixation is stable, this area of resorbed bone is not stable. So in order to have the best shot, we need to go with stability as well as biology. So again, our options. What would you choose? Yeah, Ahmed. Or anyone else? Anyone would like to participate? How would you go? Knowing that's mainly a biology issue with a touch of stability.
So I think bone grafting should be one of our options because of the biology, to improve biology.
Okay.
And then maybe bone grafting with nail exchange.
Okay, bone grafting with nail exchange. I'm glad you mentioned that. I'm really glad you mentioned that because I have noticed in our institute and many institutes for that to be an option. Why? I really don't know. Because once you read the topic, once you try to understand it scientifically, it does not make any sense. When you exchange, you're actually reaming, huh? And it did not open the fracture site. So you are depositing bone graft. Why would you see or find the need to open, to put bone graft and actually remove the bone graft you just deposited? It does not make any scientific or logical sense. However, it is so much commonly practiced even in the US, even in Canada, even everywhere, and does not make any sense. So this is a chance for us to clarify some of the misconceptions about non-union. Do you think you need to open a bone graft fracture when you chose to exchange nail it?
كيف
Sorry?
تعيد السؤال بس لهند.
Do you believe there is any need for opening the fracture site and bone grafting when your option was to actually exchange nailing? Knowing that exchange nailing, you will have to ream. So you'll deposit your ream in the fracture site and you will have bone graft there. So does anyone still believe that we should consider bone grafting? When this is our option, when there is exchange. Okay, I will assume no one. So your option was exchange plus minus bone grafting, and let's see what happened to this patient. So patient 6-3 requested a ring fixator option. Now this is the individualization part. This patient, even though you came up with excellent options, he says, I hate nails. I don't want a nail to be inside my tibia ever again. I want something that's not a nail, and I heard about this ring fixator option that I really like, so I want a ring fixator. Hexapod TSF frame was utilized, nail removed, then reaming done, stimulate blood supply and deposit bone graft. Some ream was sent for cultures, which came negative as we mentioned, and then patient was allowed to weight bearing immediately. Let's see what happened. This is the patient in frame after 7 months. You see, gap's almost gone, fracture is healing nicely, there is some callus, and patient is walking pain-free. So would our option for the first case work in this patient? Yes, as Ahmed mentioned. Exchange nailing would be a great option for this patient and will most likely work. However, in individualizing this case, patient's preference was to not have a nail in again ever. So how about the other options? Honestly speaking, all the other options except for the dynamization are valid partially or completely. Bone grafting is a valid option, however, it does not tackle stability. And as I mentioned, the others, as long as they tackle both, will be viable. Okay. Before we move to muscle, any questions about this case? Okay, so a quick brush on muscle. Muscle was mentioned actually a couple of times during those cases. Let's talk about them. It was developed in '86, well-established technique, treats bone defect using something called induced membrane concept. It has a diamond concept that muscle, just like nonunion, has very strict, very specific rules that if not followed, results will most likely not be satisfactory, okay? And when does muscle fail to work? We will talk about those specific points. Okay, so it's a two-stage principle. First stage is eradication of any necrotic tissue, any infection, anything that will impede or delay our healing. So it's mainly debridement, cement spacer, and waiting. Hello? While waiting, we need to have stability. Stability is needed not for bone formation, for membrane to form. Membrane is filled with bone morphogenic protein, with progenitor cells. They will not migrate from edge to edge if there was instability. So even in stage 1, you need some stability for the for the muscle to work, okay? And then following a period of 6 to 8 weeks, now this is mentioned from a study in 2020 by Elaine Musclet themselves. I don't know if it's a guy or a girl, but they mentioned that they need 6 to 8 weeks. This study was actually on distal tibia, foot and ankle bone defects. However, usually in femur, we wait 10 to 12 weeks, okay? After this certain period of time, 6 to 8, and in femurs 10 to 12, we open this membrane in one line, treating it as a periosteum, remove the cement, and then bone graft the area. Along with that step is the final rigid fixation construct, which can be done in stage 1, actually. If there was no infection, we can put a nail and then cement around it, then remove the cement and put graft or plate or whatever. But if there was an infection, maybe putting a definitive fixation from the beginning is not the best option. Okay. So what was the diamond concept that Musclet suggested to be completely adhered to in order for Musclet to work? You need to have adequate vascularity. You need to have the host factors, which are good nutrition, good environment, biologically. You need to have mechanical stability, and these type of mediators, which will be present once you have this and this. And you need to give appropriate time specific to each fracture, which is roughly around 6 to 8 weeks for distal tibia or humerus or forearm, foot and ankle, and 10 to 12 for femur. And you need to have an infection-free environment. Musclet does not work when there is an infection. Okay? For this biological chamber or induced membrane or bioreactor, all the same concept, which is what happens when you do Musclet, to actually happen and bone to heal, you need to have these factors, okay? All right, so key points in Musclet technique in general. Preparation is key. Thoroughly working up the patient. I suggest using the 3-step approach, even if you want to put Musclet, because it will treat the same issue, just in a different manner. Diamond concept should be adhered to strictly. Respecting for soft tissue is paramount. However, if soft tissue was the main issue facing you, which means there was a lot of devitalized tissue that you need to take out, then you should be very aggressive. Because inadequate initial and subsequent debridement, if not aggressively performed, persisting devitalized tissue creates high risk of infection, and any procedure is doomed to fail. So how do I balance between respecting soft tissue and thoroughly debriding? Is to stop at the line where the soft tissue is of value, is actually viable, is contributing to something. Whenever it's dead, just take it out. Don't leave a necrotic tissue hoping it would do something. It will not, it's dead already, okay? So when this full approach is followed, success is highly likely, and the diamond concept principles of Musclet should be included in the management for the success rate to increase. This is a Musclet case. In the comments or in the notes below are the comments. I will just mention them to you. This is a distal tibia, intra-articular open fracture with a lot of soft tissue damage that was treated with X-Fix, soft tissue debridement, then musculate technique, which is cement spacing. This is the first stage. Notice with the first stage what happened. External fixator. Any form of stability that could help. This is the patient in dressing after the first stage. After 6 to 8 weeks, patient was taken to the OR. The other tibia or the other femur was reamed for RIA or reamer irrigator aspirator output, plus iliac crest, plus BMP morphogenic protein type 2, plus bone chips, plus graftone, plus anything you have, you can mix together. And then cement was taken out by incising, as you can see here. I wish I can enlarge it. You see this line, it's like a fascia. The membrane was treated like a periosteum or fascia. One line incision, filling off the bone defect, then closing the pseudomembrane or induced membrane on the bone graft, and then giving it time to heal. While they were doing that, they changed the fixation methods from X-fix to a nail. What kind of nail techniques is this? Anyone?
Trigen nail.
No, it could be a trigen nail, I agree, but this is actually
ankle
Arthrodesis, yeah. Ankle arthrodesis.
So it was an interarticular comminuted fracture. And with the debridement, a lot of bone was taken out. A lot of bone was found to be actually crushed like powder, so they could not save the joint. However, they were able to save the limb, okay? So this is tibio-calcaneal constructs, but the nail length does not seem to be a TTC nail. The longest is 25 centimeters, should stop around here. So they might have used a femur nail, retrograde, because it is straight. That's the only option, I think. And that's the result. Healed. See the bone? Fully healed. So this is one application of muscle-A. It can be done in diaphyseal, metaphyseal, epiphyseal, interarticular, foot, ankle. Theoretically, muscle-A can be done in every bone in the body. Okay? But you need to have the rules adhered to completely. Do not expect muscle-A to do wonders for you. It has to be strictly followed, okay? So, for any patient in muscle-A, ensure all of them have suitable prophylaxis, like enoxaparin for at least 6 weeks. For tibial injuries, mobilize toe, touch weight bearing. Foot and ankle, no weight bearing is advised. Wound inspection at 2 weeks, as you know. 6 weeks follow-up for X-rays. X-rays are followed up until there are radiological signs of union and pain-free immobilization. So 2 things: bone breaks on the X-rays, and there is no tenderness locally at the bone itself. Summary: know the condition in which bone has the biological and mechanical environment to heal. For all our presentation, you need to have proper biology and proper mechanics for any fracture to heal. There is patient, injury, and certain factors that we need to take care of. And this all goes back to proper history taking and physical examination, and then proper workup. 3-step approach is a proper and vital and effective way in navigating non-unions. Finally, individualize your treatment. Have a backup plan. Discuss with your patient, what do they want? Some patients will tell you. One patient that came to our hospital a month ago, he had crushed calcaneus, and he told us, I want 1 surgery that I will get at the hospital tomorrow, which was a weird request. We told him, you will need to stay 6 weeks to 3 months at least. It was open, infected in another hospital somewhere else. So we told him the only option that would provide that is amputation. But we would not recommend it because there is a chance for healing. He said, no, please, I want you to amputate my foot so I can get out of the hospital. And that was the treatment. So you need to individualize. Okay. By this, I conclude my presentation. Thank you so much for listening, and I will receive questions now.
الله يعطيك العافيه دكتور فيصل. بس عندي سؤال، ليش في الفيمر نخلي السبيسر فور 10 ويكس؟ يعني ليش في التيبيا 6 to 8 weeks وفي الفيمر 10 to 12 weeks?
Well, I believe in my very limited search about this specific reason, that was the femur takes longer actually to develop the pseudomembrane. I think it might have something to do with the big surface area. We've done a lot of cases of musculae where inspecting at 6 weeks, finding no membrane or very little membrane, that's incomplete. So the latest recommendations for femur to give it a little bit more time. And our practice actually, even for tibia, we do the same. And I think in this study, what gave them the outcome is the fact that it was a distal tibia, which can be treated as a smaller area like a foot and ankle fracture or a forearm or even a humerus. But for tibia shaft, we wait 10 to 12 weeks, and for tibia shaft, we give it also 10 to 12 weeks.
الله يعطيك العافية. بس برضو في سؤال ثاني دكتور، فيه definition للديلي non-union؟
Okay, so there is non-union, we defined it as no signs of healing at 9 months, depending on the fracture itself, but in general, or 3 consecutive months with no radiological changes. So these two definitions are for the non-union. Anything short of that can be called delayed union, given the condition that the fracture has exceeded the original time, which is 6 weeks to 3 months, but did not reach the 9 months, or there is some subtle changes but still late. هذه delayed union. يعني مثلا fracture له 5 شهور showing progress but very slow progress is delayed union. fracture له 4 شهور ومن 3 شهور اللي فاتت الى الحين والشهر الرابع ما في اي change is delayed union. 5 شهور وشهرين ما في change is delayed union. 6 شهور with 3 months consecutively no change, it jumped the threshold to non-union.
الله يعطيك العافية. شكرا ما قصرت.
عفوا الله يحييكم. أي سؤال ثاني يا شباب؟ أنا أشوف في واحد من الشباب كتب TTC يس على النيل اللي قبل شوي. Yes, excellent job. It was a TTC nail. اللي هو تيبيو تالوكالكينيال nail. Okay. Any other question?
الله يعطيك العافية دكتور فيصل، ما قصرت. في عندنا دكتور في عندنا MCQs بول اوف MCQs، خلينا نحاول نجاوبها مع بعض الدكتور.
ممتاز. Let's go.
مرام.
تمام واضحة؟
اي واضحة. مرام دقيقة عشان بس البول الثاني عشان نقدر نشغل البولس. تقدر نشغل البولس من
أيوة أقدر أشغلها.
مرام على بال ما تبدأي، دكتور فيصل في سؤال بعد إذنك يا مرام.
أوكي تفضل.
تفضل في سؤال.
ايوه دكتور فيصل الله يعطيك العافية. Is there any difference or is there any effect on the union if immediate nailing in 3B fracture tibia? 3B fracture tibia, immediate nailing and X-fix.
Okay, so allow me to adjust the question just to make the idea very clear. Choice of fixation does not have any, it has nothing to do with the fracture type as opposed to the soft tissue status. So 3B means there is a soft tissue loss requiring reconstruction, not skin graft, but a flap. So if you don't have the flap, if the bone is exposed, definitive fixation is discouraged completely. And you need to cover the fracture with back dressing or something until there is a soft tissue coverage. Okay. However, if there was a soft tissue coverage immediately with the 3B and there is no signs of infection, nothing against it. But the common standard practice is you don't count on the first washout. You don't take cultures from the first washout. Came trauma fresh to you or delayed, and you did the first washout, you consider anything contaminated. The second look, 48 to 72 hours later, is where you do the washout first, and then you take your cultures as per AO recommendations. So if you don't have a strong evidence of cleared infection, I wouldn't put any differential fixation, صح?
Yes. Okay.
So that's the main principle. Okay.
شكرا الله يعطيك العافية.
Yeah. So هذا الquestion.
طيب, first question is 32 years old male non-smoker patient sustained a left closed tibia shaft fracture 15 months ago that was treated with an unreamed tibia intramedullary nail. 5 months ago at the 10 months follow-up appointment. Radiographs revealed a distal interlocking screw were found to have broken, at which point surgery was recommended, but the patient refused. Figure A and B are the recent radiographs of the tibia. Recent ESR and ESR and CRP levels were normal. What would be the best treatment option at this time?
Okay. So if you would like to show the options, ما في مشكلة, but before we answer, let's all think about our 3-step approach and try to apply it to this patient. Why did the fracture not heal? Is it biological, mechanical, or extrinsic? And what can we do to correct those causes? So as you can see in this vignette, not all the information you're seeking are present, but usually in questions in board exam, in residency exams, in OITE and AOS, they are trying to direct you somehow. So they mentioned something about infection not being present. They're trying to make you think about sterile type of non-union, if you can get the point, okay? And the periods and the broken screws and the hypertrophic fracture characteristics are all pointing towards that. That does not mean you shouldn't culture, you should culture, but I think it's kind of safe to assume that there is no infection. Let's see the options. Okay, so our options are continued observation. And شيء ثاني في الاوبشنز دائما في الاكزام بشكل عام, some options they are trying to steer you very clear from just to fill up the gap. So don't overthink, just take it simple and try to see. Antibiotic coated intramedullary nail with IV antibiotics. So why would we consider antibiotic coated nail with IV antibiotics if there is no infection? That would not make any sense, honestly. صح? Replacement of distal interlocking screws. So this is tackling one issue, which is the broken screws, which are not really an issue. لو جاني patient عنده healed fracture with a broken screw, I would not recommend removing it, صح ولا لا? So this would not treat something. Would not treat the big issue, which is non-union. Reamed exchange nailing, what would this treat? Would it treat biology? Yes. Would it treat mechanics? Yes. Would it help in healing or in solving the non-union part? Yes. Unreamed exchange nailing, actually the first time they did unreamed and it failed. So insanity is doing the same thing, expecting different results. So of all the options here, only one option is actually presenting a different approach that's actually directly tackling the non-union, fixing our two main issues, which is in this fracture, stability is the main issue. Screws broken because the nail was moving too much. And hypertrophic non-union means that there was a lot of motion. And there was a gap as well. If you can go back to the image, you will see there was a gap. So biology was also an issue. So out of these options, I would recommend number 4. Let's see what we have. What is the full answer? Oh, sorry. أنا خربت الجواب عليكم الظاهر. Okay, from the next question, we'll just wait for the guys to pull, then we'll discuss. Okay, have results ولا أي شيء؟ Okay, ممتاز. So for the
هذا بعد الغش هذا.
اي ممتاز ممتاز، بس اذا بعد الغش في 4% chose other options, we need to actually circle back to the options here. Might be chosen by mistake, but if anyone who chose these options believes in them, please let's discuss. Why do you think antibiotic is an option, or why do you think replacing the screws would solve the issue? Anyone? هنا كلنا أنا جاي أتعلم وأنتوا جايين تناقشون، كلنا جايين. أنا I'm planning to إني أطلع من هذه مستفيد. اللي اختارها believing in it for some reason, please discuss. We might be able to change your mind, or you would be changing our minds. حتى لو يبغى يكلمني بعدين private يقدر ياخذ رقمي من أحمد. Okay? All right, let's move. Next question if you have.
Okay, the next question is 19 years old man underwent IM nailing of the closed tibia fracture 1 year ago and had never been pain-free. While playing football, he was tackled and sustained the injury shown in figure 24A. What is the best treatment option based on the radiographs seen the next two figures?
Okay. Options.
Can you put back the picture again, please?
Okay, so the poll is over. Let's go back to the question. So as you can see, this patient had a fracture of the tibia. He was tackled, he fell down, and he has presented with this image. Okay? تسمعوني صح؟
Yes.
ايوه دكتور.
Back to the image بالله يا أحمد. ولا whoever's handling the imaging. طيب, what you can see here is actually there was no healing to begin with. He might have been mobilizing, no pain, and living. He was actually playing football. So this would indicate that, he has never been pain-free, but he was also playing football. So you see, even when the questions, they are trying to push some agenda always. He has never been pain-free, meaning there was non-union. But even if he was pain-free, some patients are, still there is a clear chance of no fresh fracture. There are blunt edges, kind of circular in some areas, and the fibula is broken, also with some signs of attempts of healing. There's some bone, this I would call it oligotrophic non-union, or the horse hoof, because it's not very big, but there is some bone trying desperately to bridge. Characteristics of the previous fixation: patient had a nail, and you can see some gap between the canal and the nail inside, right? So definitely there was a stability issue. Also, not much callus, so also there was a biological issue as well. Patient was never pain-free. And then he presented with this issue. What would be our options? So going back to our 3-point approach, why did the fracture not heal? As I mentioned, there is definitely a stability issue. And if there wasn't, after a year, there is. And there's also a biological issue. Extrinsic factors in a 19-year-old are less likely to happen. However, he might be a smoker, which can contribute. We need to work up the patient always for infection, endocrine, and taking the full history and examination, okay? Also in the index procedure, even though it seems closed and there was no opening, but we need to check. Maybe he was perfect, but someone decided to open and reduce and strip the whole fracture, causing biological issue locally. So you always have to keep that in mind. Circular fixator, it's not a wrong option. However, it only tackles one aspect, which is the stability. It does not tackle the biology factor, so it makes it less than perfect of an answer. Exchange nailing, as we mentioned, is a valid option that covers both stability and biology if it was done right. Exchanging the nail with the same size nail is not gonna deliver stability boost. Also, one thing I did not mention before, when you ream for exchange nailing, try not to exceed reaming by 1 to 1.5. Don't ream above the nail size by 2 or 2.5. You will not achieve that breast fit stability of the nail. Iliac crest bone grafting is a valid option that will tackle what?
Biology.
Biology only. Is there anything about stability in there? I don't think so. And straightening of the leg and casting is the laziest option. It might work if the casting was molded right, but it's a far-fetched option in a long bone fracture in a young healthy male. صح ولا لا؟ ما أعتقد إنه someone would consider this as an option unless there are patient factors or individualization factors that would push you towards it. Otherwise, it's not an option. Removal of the nail and functional bracing is preaching the same concept here, except he did bother to remove the nail. At least this guy would just keep the nail, I think. And both options are not realistic. So as you can see from these options, you need to see which one fits best your agenda. If there was an infection, which one tackles that? If there was a defect, which one tackles that? If there was stability issue plus biology, or only biology or only stability, which one does tackle that? So before we move to the next question, can you give me a scenario where only biology, no infection, sterile, non-union, with only biology that needs to be tackled? What do you think? Because most of the time, both, صح? Presence of non-union indicates some instability. But there is a scenario where only biology is an issue.
For example, I think infection is.
Yeah, other than infection, you are correct, but other than infection. So let's say a patient was fixed with compression plating. Hello?
Osteoporosis, for example.
Yeah, okay, it can be, صح? But it's all about, if you want to see only biology, you need to think about mechanics. If the patient was fixed with a mechanically stable construct that is resistant to strain, that is not too rigid, yet not too rigid is actually an option too as well, not too loose, then only biology would be considered. يعني مثلا iliac crest bone grafting would be considered in a tibia fracture if it was treated with compression plating and there was a gap. Where does this gap usually happen, or where would you bone graft? هذا a common question. Posterior lateral corner of the tibia. Posterior lateral corner bone grafting, if you look it up, is the usual place where defects happen when you treat the fracture with a very rigid construct, or not very rigid, like a stable construct, yet you face oligo or atrophic non-union. Because if you have a stable construct, you would never see hypertrophic, of course. So hypertrophic means motion. So if you have a very stable construct that needs only biology, usually compression plating of the tibia shaft with posterior lateral bone defect. هذا mainly the only option. You will need only 3 as a correct answer. Okay, other questions you have?
عفوا دكتور, how about in the case of smokers?
Okay, excellent. In the case of smokers, if whether a patient smoker or not, endocrine issues or not, it depends on the mechanics as well, صح? Because if you want to correct everything. If a patient was a smoker or not smoker and fixed with a nail, you would want to improve stability by exchanging or adding a plate. But if he was fixed with a compression plating and he's a smoker, he will have atrophic or ligotrophic that you will need to have smoking cessation plus bone grafting. No need to change stability as long as it is stable. هذه الفكرة اللي بوصلها.
أقصد يعني I meant إنه as an example of only biological causes rather than mechanical causes for non-union.
True, but still, if he was a smoker and he had a nail, and there was non-union, there is a stability issue that you need to tackle, as well as biology.
I see. Okay. شكرا.
The next question, which of the following non-unions are appropriately treated with exchange rib nailing without bone grafting augmentation? Infected tibia shaft non-union 6 months, that's post IM nail fixation. Oligotrophic humeral shaft non-union 7 months, that's post non-operative management. Hypertrophic tibial shaft non-union 7 months, that's post IM nail fixation. Comminuted open tibia shaft non-union with segmental bone loss 8 months, that's post IM nail fixation. Supracondylar femoral shaft non-union 6 months, that's post IM nail fixation with 4 distal locking screws.
So, this question, in my humble opinion, should not exist. I honestly believe, because if you exchange reamed nailing, you should not consider bone grafting unless there is an infection. It should not exist as an option. So the question is, which of these fractures should be treated without bone grafting? I believe all of them, except if there was an infection. Otherwise, it's always the case. However, let's see if we can answer this. So I guess you guys caught the agenda they're trying to push here. So the idea is, which of these fractures, I think the idea was, which of these fracture has absolutely no chance of having biological factors as an issue? I think that's the more proper wording of the question, not adding or subtracting bone grafting. Which of these fractures has absolutely no chance of having, or least likely to have, biological issue, which is hypertrophic. Hypertrophic means the biology is optimal, however, stability is the issue. The other fractures, there is a biological factor, whether it's infection, oligotrophic, comminution with bone loss. This one, supracondylar, usually the blood or the vascularity is an issue, so it is also biological. The only one that does not have anything even remotely biological is a hypertrophic tibial shaft non-union, 7 months, that's post-intermedullary nail fixation. And also you can exclude 1 and 4 from the period. How would you define as non-union 6 months unless you have mentioned 3 consecutive months of no changes? طبعا هم mentioning non-union would be enough, لكن you should keep in your mind, sometimes this can help going back to the definition. However, I think the main agenda here is hypertrophy means biology is to some extent adequate. Okay.
دكتور فيصل الله يسعدك، بس عندي سؤال. المسكوليه تكنيك له ليميت معين في اللينثنينج؟ يعني مثلا في عندي تيبيا والتيبيا how long I can use a muscular technique يعني defect في التيبيا؟
Yes, no, there is actually no limit to the defect utilized by musculae yet.
يعني I can manage it with 10 and over of 10 centimeters.
Yeah, I have a case we did that was, I think, 14 or 16 cm that succeeded. So It's not about the gap, it's not about the size of the gap, It's about the diamond of muscle A.
Okay.
Once it's achieved regardless of the gap. أو also the location makes a difference. يعني لو مثلا في شيء interarticular, you don't expect the joint to come back with the muscle A, you just have to bypass it. Otherwise, no, there is no known limit to my knowledge.
Okay. Thank you.
Okay, so Ahmed بريحك شوي بقرا السؤال. Isolated exchange interlocking nailing is most likely indicated as the next step in the treatment of which of the following clinical scenarios. So isolated here means with no added bone graft, which should not be an option. Should not be an option. However, let's move on. Tibial shaft non-union with a 4 cm bone defect, infected tibial shaft non-union, hypertrophic diaphyseal tibial non-union, atrophic shaft non-union, or hypertrophic metadiaphyseal distal tibial non-union. So let's think in the same method we thought in the last question and let's answer. Okay, any poll or you want to move? Okay, so I agree with the answer chosen by the majority. So this is the same idea, but it added one little concept. Which of these fractures is less likely to have a biological factors contributing to the need of added bone grafting, even though it's not needed, guys? But that's the idea I think they are trying to reach. And of these options, there are two options that are a little bit confusing. There's the hypertrophic metadiaphyseal and the hypertrophic diaphyseal, right? So what made you choose diaphyseal over metadiaphyseal?
Metadiaphyseal usually goes with compression plating better than exchange nailing.
Okay, so that's an idea. I think, okay, so what I believe is hypertrophic diaphyseal tibial non-union has a mechanical issue that can be tackled with nail alone. However, I think that's their idea, صح Ahmed? إنه you will add plate here.
Yes, I'd add plates في metadiaphyseal.
Why?
Because epiphyseal area is weaker than the diaphyseal area and has يعني stability will be affected more في الشافت أكثر. So nail will be better.
فكر فيها بطريقة أخرى. الحين يوم تحط النيل في diaphyseal fracture. What is above the fracture and below the fracture? It's diaphysis, huh?
Yes.
So there is no change in diameter.
صح.
However, in metadiaphyseal, you cannot control the metaphyseal part. عشان كذا دائما تلقون nailing في metadiaphyseal fracture is more challenging because it has a wider area for the nail to wiggle. So if you want to really correct stability, you need to either have an added plate in a metadiaphyseal fracture, or you need to figure something out to increase stability other than nailing, because nail will not. لو تحط nail size 17 أول شيء ما راح يدخل في diaphysis بس بيمسك الميتافيسيس. فما لي ايش الحل الثاني؟ اني احط nail that is fitting the diaphysis completely and supplementing with a plate. So now since you opened and supplemented with a plate, what do you need to do? You have two options. You either start with this plate and it will be weak usually لأنه بيكون unicortical. It will be unicortical either way عشان diaphysis بس you might be able to redirect if you put it first proximally or distally. However, you either need to start putting your plate first and then closing the fascia and then exchange nailing, and then you don't need to graft, or you need to exchange nail, and then when you finish, you open and put your plate, and at that certain scenario is where bone grafting addition is appropriate. لانك فتحت الفراكشر طلع الجرافت اللي انت حاطه that is not contained anymore, so you need to supplement with the graft. واضح الفكره؟
يس.
ممتاز.
طيب دكتور فيصل، بس معليش، لو انها في الميتافيسز ودخلت سبرا باتيلر بروتش،
اوكي
do I need to put a plate ولا خلاص
ممتاز.
يعني اكتفي بوجود النيل يعني من داخل سبرا باتيلر بروتش عشان امنع
ايه فهمت عليك. It's an excellent point. Even though suprapatellar approach would make the deformity easier to handle, would make the alignment more likely to be achieved, it's not an alignment issue, it's actually a diameter issue. It's a diameter difference issue. لأنه حتى لو حطيت perfect alignment لسه الميتافيسيال area has a lot of room for motion. The plate idea is not to hold the reduction for the nail to be aligned, it's to decrease stability at the fracture site. هذه المين idea behind it. واضح؟
واضح، الله يعطيك العافية.
Okay. You have more questions, guys? ممتاز. Which of the following factors has been shown in a clinical trial تحجير السؤال to be equivalent to autologous bone graft for treatment of tibial nonunions that were treated with intramedullary nail? So the question is not okay. ممتاز. حتى الأجوبة ما هي confusing. So which of the following factors is equivalent to autologous bone graft? Let's see. ايش رايكم يا شباب؟ Let's see. هذا ortho bullet question حق مذاكرة حق اختبار. In real life it has less of a value than an exam. ممتاز. So this question is asking about bone morphogenic proteins. There are two approved BMPs in treatment of bone fractures by FDA, which are BMP2 and BMP7. BMP2 has a specific indication, which is acute addition in an open tibia that is clean. BMP7 is for non-union. Okay. So كيف أنا أتذكرها دائما؟ BMP2 falls under the range of Gastello, which is 1, 2, and 3. So it's for open. BMP7 is beyond that, so it's for non-union. However, in reality, I've never seen BMP7. We use BMP2 a lot, even for non-unions. We have never seen BMP7. I don't think it's available, at least not in our institution ولا حتى في التخصصي. ولا في الجامعة ولا في العسكرية. أنا اشتغلت في أكثر من مستشفى ما كان في أصلاً هذا as an option. Even though these centers do a lot of non-unions وفي حتى مسوين big studies pooling tens of cases of muscular. BMP2 was actually utilized in those studies. I was part of one of them. BMP7 was not an option. الفكرة اللي يحاولون يوصلونها هنا إنه BMP7 احفظوا. It's a bone substitute. It's actually very expensive, tens of thousands of riyals, but it works as a bone graft, autologous bone graft. Okay. "56-year-old male, type 3B open, comminuted tibial shaft fracture, distal to a well-fixed total knee arthroplasty that is definitively treated with a free flap and X-fix, definitively." Okay. 9 months after fixated removal, he presents with a painful oligotrophic non-union. Laboratory workup for infection is negative. Passive range of motion is limited to 15 degrees. What is the most appropriate treatment for this non-union? So 3B open, comminuted, tibial shaft, it's a shaft fracture, فوق total knee. يعني هو يبغى يخرب عليك بعض الأوبشنز مو مشكلة. Definitively treated with X-fix and free flap. والحين جايك بأوليجوتروفيك. So oligotrophic means you need to think about if there is an infection and there is no infection, negative. So you need to think about biological factors and definitive treatment with an X-fix. أفخم أكشخ X-fix في الحياة has the stability of what? Same range as a cast. Same range of stability as a cast, crossing over to some nails. لو تشوفون range of stability depending on fixation تلقون X fix between cast and nail. So definitely there is a stability issue without even seeing the fracture, and oligotrophic indicating some biological factors. Let's think about why the fracture not here and how will any of this treat it. Okay, so a lot of debate in this question, and it is well expected. خلينا نشوف. Let's take them one by one. Manipulation under anesthesia. يرحم أمك لا. It's not an option for treating non-union. And stiffness. This is not the time to treat stiffness. First, you need to have sound bone, then you can handle stiffness. Hello. Like cast immobilization, use of a bone stimulator. Okay, so theoretically this is not wrong. However, patient was immobilized for a long time. There is non-union that we need to tackle both biologically and mechanically. So this is not the best mechanical option. And bone stimulator might be a good biological option, but still without mechanics, biology will not work. Unilateral external fixator, again, doing the same thing, expecting different results is the definition of insanity. Intermedullary nailing or compression plating are the real true options that we can handle. However, let's think about it. Can we nail when there is a tibial tray? Is it possible to nail when there is a tibial tray? Theoretically, you might be able to get away with it if you have a too much anterior starting point. However, in reality, it's not an easy option. It can be done, but it's not an easy option. Compression plating, you have one challenge, which is the flap. However, you can call your plastic colleagues to raise the flap, and then you can do compression plating. Now, nailing has one advantage, which is I would assume they would ream, which would provide biology, and it is an oligotrophic, isn't it? Oligotrophic. So there is need for biological intervention. Plating might compensate some of the biology, but you need to have graft with it as well. This is actually a confusing question for me as well. But I chose, knowing that nailing is a difficult option, I chose compression plating. I could be wrong, but if I can get away with the nail would be superior. If I'm in doubt, أنا جاوب بناء على البراكتس حقي. I've never nailed in the presence of a tibial tray, and I wouldn't consider it as an option. I would go with the submuscular plate. But if there's non-union, I would open, compress plate, and graft. So this is, I think, a more appropriate option if I wish they added graft there. Okay. More questions? أحد ثاني يقرأ السؤال.
طيب.
50
years of male presents for initial evaluation of his left leg, which sustained a closed tibia fracture 24 weeks ago. Injury films are shown in figure A, at which time he undergoes uncomplicated intramedullary nailing of the tibia. He has persistent pain with weight bearing. Updated radiographs shows intact hardware, no malalignment, and no bony union. Inflammatory serologies are within laboratory reference ranges. His soft tissue envelope appears healthy and intact, which of the following is likely to contribute to achieving osseous union?
Okay, I think those X-rays are pre-fixation, I believe. ما في nail أصلاً هنا. بس إنه سؤال in general or basic science question, which of the following is likely to contribute to achieving osseous union in a tibia fracture, I think. Especially in the one who did the nail with no alignment, but no bone union. Okay. طيب. Let's review the options again. أول شيء let's review the case again شوية أنا لاحظت مخي. Closed tibia 6 months ago. He undergoes uncomplicated nail of the tibia. He has persistent pain with weight bearing. Updated the graph show intact hardware, normal alignment, no bone union. Inflammatory serology are within normal limits. Soft tissue envelope appears healthy and intact. So, if the patient has no signs of union, what would be the options? Remove the nail, convert it to cast is not an option at all for me. لأنه it's downgrading stability, and you need to keep or increase stability always. Exchange nailing with a solid nail of equal diameter and length. Now this is doing something to improve biology only. However, it does not improve stability because exchanging was not done in the proper manner of increasing 2 sizes minimum. Osteotomy or periarticular or partial ostectomy of the fibula. Now this is an option that used to go with dynamization. Having a debate about dynamization or thinking it's not the best option necessitates إن هذه أصلا ما هي option أساسا, especially if the nail was well fixed or in place. ما راح يصير dynamization الحين. Addition of bone morphogenic protein BMP3 to the non-union site. I don't know what is this factor and if it actually exists. It might exist, but it's not used, not approved definitely. Muscular technique is for bone defects, so the only option here that could make sense is 2. However, 2 will not address stability, but maybe stability was not an issue to begin with, okay? So maybe it was purely biological, since it was atrophic non-union, atrophic with no infection. This might be an option because this will stimulate blood flow, vascularity, will deposit bone graft, and will have the nail of the same stability. So I think 2 is the most proper answer here. Oh, nice. So again, it is supported in orthopedic. It is supported in some places, but not in AO. لأنه if it is what I think it is, which is giving the fracture the ability to dynamize, dynamization in the tibia is out of favor now. That's according to AO latest recommendations. However, if it was the option, dynamization, they would not only stop at ostectomy or osteotomy of fibula, they would add what should be added?
Bone graft.
No, okay, if you do not open the fracture, ما في مشكلة. I agree with you, biology is not addressed at all هنا في osteotomy. Like in dynamization, in order to have dynamization, you need to cut the fibula or osteotomize the fibula or ostectomy of the fibula plus dynamization of the nail itself. Now, is the nail dynamic or not? Not mentioned. Usually nails are static to begin with. That's the normal. Changing it to dynamic would be a point to mention. However, again, I could be wrong. Of course, everyone can be wrong, but this point is a very important point to think about. Dynamization in tibia is falling out of favor due to very specific reasons of having the tibia not having a successful record of improving with dynamization. So it's not really much of an option. Here, this will only address biology, but will not address stability, but I would choose it over anything else in these options. I could be wrong, okay? هذه مجاوبة من OIT الأجوبة.
لا هذه من orthopedics.
Orthopedics. So I mentioned that point actually specifically. Orthopedics still supports this theory. If you open non-union or tibia shaft, dynamization is still an option there. So if they still believe in it, this would be part of the concept. صح ولا لا؟ لكن I or AO does not believe in it, and that's why I did not consider it. Now, in exam, I mentioned at the beginning of the presentation, still dynamization is an option, at least in orthopedics, maybe in OIT as well. However, for your own practice, try to clear or steer clear from dynamization in the tibia, as the records shown very little success compared to the femur. Okay. Let's move on. Okay, ممتاز. الله يعطيكم العافية. صراحة very enriching, very nice questions, very good يعني preparation. أشكركم جميعا وأخص بالشكر coordinators اللي ماسكين presentation اليوم. الله يعطيكم العافية.
الله يعطيك العافية دكتور فيصل، شاكرين لك تواجدك معنا وشاكرين على المحاضرة الغنية هذه صراحة. يعني تيبيا نونيون كنا نحسب اننا عارفينها كل حاجة، لين ما شاء الله المحاضرة ذي غطت حاجات جديدة علينا كلين، يعني including فيها الابروتش وغيره. فالله يجزاك عنا كل خير ويجمل حالك.
ابدا بالعكس، الله يحييكم. كانت فرصة لي انا بعد اني اتثقف اكثر في الموضوع. ف thank you guys as well. I wish you best of luck. والله يوفقكم، سهل عليكم ان شاء الله.
الله يعطيك العافية. شكرا.
عفوا، شكرا يا أحمد.